Thanks, Ciarán. And good morning to all our guests. I just have a number of small, not small questions, but just I'm time limited because I have to speak in the chamber. And welcome to all our guests. Just in relation to the cross-border directive, is there kind of a calculation of how many people are availing of the cross-border directive? And obviously that has kind of slightly changed in the last 18 months because of Brexit and so forth. But is there a number that, you know, the doctors would have at hand that, you know, people are availing of this directive?
I'll take that. Thank you very much, Deputy Kenny. This is one area that does concern us because we don't have full visibility on the patients that are being referred directly out of the state to avail of the cross-border directive. And obviously they're coming from all parts of the country. And prior to the VSAs, we had made an assumption that the actual travel of patients from the nearest region that we talk about today was actually very low. But it comes from, when my colleague Jean-Paul Teeling did voice of the customer with the referrers, we came to realise that large numbers of patients, up to 20 a week from one optometric practice, are being referred to Belfast for surgery. So this presents a problem for us in that we can't fully demand model. So how much capacity do we actually need? So we're basing on our current wait list for current and demographic growth. We may need to bring more capacity in as we get a better idea of what the full demand is. But we've engaged with the optometrists and GPs in the region through this process. There's been really broad engagement and agreement that this is the right thing to do. In fairness to the referrers acting on patients' interest, they feel they can't switch that system off till this is fully up and running. We're excited to be getting our new theatres so we can demonstrate that tripling of the capacity for cataract surgery through the matter so they won't need to do it. But I do need to point out, and I think this is often a misconception, that the treatment abroad to Belfast are patients going up to an NHS unit to be treated up there. They're going to a private facility in Belfast. So we actually have the bizarre situation in another role where I do surgeries in the Mater Private Hospital. I'm asked to operate on patients from Belfast, from the NHS services in Belfast, come south to Dublin for their surgeries. So there's an odd situation in the island where we've got patients from the Republic going to Belfast for surgery and patients from Belfast coming to Dublin for surgery. So again, through NERIS, we're hoping that we provide enough capacity through this model that we will address our demand in our region. And on the modelling, and it's in the slide deck actually that I showed you there, Jerry Kelleher's and Alison Dingle's modelling, is that we would actually hit that point in about 3 to 4 years' time, and then we would have extra capacity to deal with the other parts of the country if they haven't addressed it themselves already by then.
And would that be common, people coming from the north of Ireland down to the south?
I can't speak for other private hospitals. I haven't gone specifically looking for that information and across other disciplines, but I do know that in areas like cardiothoracics and orthopaedics, there'll be a lot of referrals down, and more recently we've been asked to manage vitreoretinal, so diabetic patients with hemorrhages, back of their eyes, or retinal detachments that have been referred back down to us, and then more recently cataracts. But you've got to look at your capacity. So a lot of the work has not actually been taken on because you've got to look at the capacity and the way the HSE is deploying private hospitals at the moment to try and help with the public wait list also. And I know that's due to end shortly. So the priority will be on helping in that regard. But there is, it's a sizable enough number. I don't have the exact figures for you, Deputy. I can get those for what actually comes into Mater Private through that route. But just that you're aware that pathway exists also back the other way.
And just my final question was, a lady came into my office a number of weeks ago in relation to this very, very issue. And I wouldn't really deal with that much in relation to constituency work. But she showed me the letter that she received back from the HSE in relation to how long will she be waiting for cataract surgery. And this was a routine operation. And I couldn't believe it, what actually she showed me. She said in the letter that she'd be waiting up to 5 years for a routine appointment to see a specialist. And it was obvious, you know, I'm not a medical expert whatsoever, but it was obvious this woman is, you know, her deterioration of her eyes would seriously deteriorate well before then 4 or 5 years. And I've obviously said to her, look, I think you couldn't wait that long. you know, and obviously you have to look at other alternatives. But I mean, it's incredible that somebody has to wait up to that period of time for a routine appointment in relation to a deteriorating situation where it is.
I couldn't agree with you more that should not happen. I mean, that is the whole driving force behind this initiative. That's how we've pulled the 200 stakeholders in the region to do it. And I don't want to answer just with glib words to that. In this day and age, nobody should wait 5 years for an appointment to go and see a specialist. So that's why our target is, in the first year, nobody be waiting more than 12 months in our region. We can only control what's in our realm at the moment. And even 12 months isn't good enough. So we welcome the Sláinte Care goals of reducing that to less than 3 months in 3 years' time. And really, our target is on-demand service care, service delivery. And we want to be judged at that level. So, and the impact, and while the vision impairment and blindness from cataract is reversible with surgery, you can't escape the fact that an individual has to live, let's say, unnecessarily in a first world country with a vision impairment or blindness as a result of that. And that's why, that's our purpose pyramid, is to reduce that burden of vision impairment and blindness. So with respect to cataract, the sooner somebody sees a specialist, the sooner somebody goes and gets their cataract surgery, then we've achieved that goal that we lay down for ourselves. So everything about that, and if you did get a chance to read the presentation, everything, timely access to care, reduced waiting lists, right patient, right place, right time, transformation, education, all those pieces are supports to ensure that we reduce the burden of vision impairment and blindness, like you talk about that lady who came in to see you. And it is shocking, but that's what drives this group.
Yeah, and Dr. Keegan, obviously in this situation, what do you know, if somebody comes into my office or another TD's office, what do you say to somebody in relation to that situation where it's going to take 5 years for a routine appointment? I have the letter in front of me, but this is a routine kind of, just an appointment. The appointment alone will take 5 years. What do you actually say to that person? What do you advise in this situation?
I am surprised. Well, one, I would have retriage. So one of the aspects that we're looking to do is the quality of letter that comes in. And that's not to bounce back to the GP or the optometrist, but what's been loud and clear from our work with the cataract team, led by Tim Fulcher and Lisa McInerney, is when they worked at the standardised referral, the GPs really want the optometrist front and centre and engaged on this with support from the GP services. So that gives a more accurate referral coming in. So you can risk stratify the referral coming in for starters. That's not the full answer. But then with that information, you triage the urgency if somebody needs to be seen. They've got comorbidities, they might have diabetes as well, or other issues, or they may just have good vision in one eye with that, and they should be expedited. But really, in this day and age, 5 years, there shouldn't be anybody waiting 5 years. The target is, for our, I can only talk to our region, Deputy Kenny, and the target is to be down to less than 12 months by the end of the year for everybody, and then, a year after deployment, and then within 3 years, a 0 to 3 month wait list as an absolute. And we are also, and unfortunately, patients are accessing care through the emergency services, so we've got a disproportionate amount of patients accessing the eye emergency departments in the Manor Hospital, or the Eye and Ear Hospital, or Cork, or elsewhere, around care that should be delivered through an outpatient setting. So the first step I'd advise that lady is back to optometrist or GP, a fresh letter in stating the urgency, and just see that it's triaged appropriately, I would hope. And I'm more than happy to discuss with you or offline directly about that. Now, we can't take all cases in, but sometimes it's an index shocking case like that that drives change sometimes. It shouldn't take it, but we will react to that and we'll give an answer.
Thank you very much.
Thank you.